First of all, I'd like to thank the organizing committee and the scientific committee for inviting me to participate in SSRC. My presentation will be the role of macrophage migration inhibitory factor in ankylosing spondylitis activity and progression. Ankylosing spondylitis is a chronic inflammatory form of arthritis that predominantly affects the axial joint and has a global prevalence of 1%. Disease progression is marked by osteoproliferation and bone fusion in axial joint, causing considerable loss of mobility, and about 30 to 40% of patients experience rapid disease progression. The delay in the diagnosis and initiation therapy may contribute to the undeterred progression. And despite the fact that 90% of AS patients are positive for HLB27, the pathogenesis of inflammation and spinal fusion is not well understood. The co-occurrence of subclinical gut inflammation in about 50% of AS patients indicates that the gut joint axis might be critical for establishment of the disease, and the autoantibodies have previously been reported in AS and with high titer of anti-autoantibodies to the invariant chain CD74 of major histocompatibility complex class 2, which was seen in spondyloarthritis patients. CD74 expressed on the surface of antigen-presenting cell with high affinity receptor for macrophage migration inhibitory factor, and is potent pro-inflammatory cytokine implicated in several diseases. The elevated serum level of MEF level have been reported in AS, with the role of macrophage migration inhibitory factor in bone formation has been subject of controversy. Binding of MEF to CD74 initiates the downstream signaling pathway leading to cell proliferation. Previous researches and studies showed that serum MEF levels are significantly higher in AS patients compared to healthy control, and the MEF level in AS synovial fluid also is higher than RA and OA patient, osteoarthritis patient. Also, they identified an unknown role for MEF in bone formation in AS by having direct stimulatory effect on osteoblast genesis, possibly by targeting Lwent beta-catenin pathway. The aim of our study was to determine the role of macrophage migration inhibitory factor for ankylosing spondylitis activity, and if has a role in prediction of spinal progression. This cross-sectional case control study were conducted upon 110 randomly selected people from Rheumatology and Rehabilitation Department at Al Hussein University Hospital, Cairo, Egypt. The population study was divided into two groups. Group A, 50 patients with ankylosing spondylitis who met modified New York criteria for AS, and Group B with 60 healthy control. Inclusion criteria: patient with AS who met modified New York criteria for ankylosing spondylitis, and patient for more than 2 years duration at least, and patient should have at least 2 sets of radiographs available at least 1 year apart. Exclusion criteria: patient with other classification of spondyloarthropathy like psoriatic arthritis, enteropathic arthritis, and reactive arthritis, and patient with any other autoimmune disease. All patients were subjected to the following: complete history taking, full physical examination including BASDAI score, and laboratory investigation with HLB27, MEF by ELISA, and the radiograph of X-ray cervical, lumbosacral vertebrae, both dorsal and lateral view, and the ultrasound for assessment of enthesitis, especially in Achilles tendon. Modified stock ankylosing spondylitis spinal score based on radiographic finding to detect progression. It assesses the erosion, squaring, and sclerosis in cervical and the dorsal and lumbar vertebrae. By assessment, it takes 0 if no abnormality, 1 if there is erosion, sclerosis, or squaring. It takes 2 if there is syndesmophyte without bridging, and it takes score 3 if there is syndesmophyte with complete ankylosis or bridging from vertebrae to another. Demographic data of the participants: the majority of patients were males, about 66%, while 34 were female. Also, most of them were on the MARDs, about 88% on the MARDs. and only 14% of patients on anti-TNF. Regarding the radiological find, 92% of patients with lumbosacral erosion or sclerosis, while 88% with cervical erosion or sclerosis, and only 72% with encephalitis and signs of inflammation in the ultrasound. Regarding the laboratory data, there was significantly high, statistically significantly high increase in ESR, CRP, and DMF in patient group in comparison to the control group. The 50 ankylosing spondylitis subjects were further classified according to erosive radiographic progression into two independent subgroups: non-progressor group, 35 patients, and the progressor group, 15 patients. The comparative study between the two groups reveals that significant increase in the age and the male gender in progressor group compared to non-progressor group. Also, there was a highly significant difference increase in the disease duration, smoking in the progressor group compared to non-progressor group. The comparison between two groups regarding the laboratory data showed that there was highly significant increase in the ESR and DMF level in progressor group compared to non-progressor group. And surprising, there is the HLB27 not effect, and this may be due to HLB27 play an important role in the extraspinal or extra-articular manifestation other than the spinal manifestation. There was highly significant increase in the MSS score, and those with high score also have variable regarding the dorsal erosion and the sclerosis with significant increase, and also the signs of encephalitis and inflammation were high in this group. The correlation analysis showed that disease duration, ESR, and the modified Stock ankylosing spondylitis spinal score had a highly significant positive correlation with the MIF level. And by applying the ROC curve analysis, the macrophage migration inhibitor factor level at cutoff point greater than 51 can predict patient with progression with sensitivity of about 53% and specificity of about 94%. Dear Chairman, to conclude my presentation, our data suggested that unexplored pathogenic role of macrophage migration inhibitor factor in ankylosing spondylitis and the link between chronic inflammation, new bone formation, and disease progression. Also, the serum macrophage migration inhibitor factor levels were predictive of progressive spinal damage in ankylosing spondylitis. The limitation for our presentation, we didn't investigate expression of pattern of macrophage migration inhibitor factor receptor CD74 and the relatively small sample size with lack of follow-up in some patients. And our recommendation, periodic follow-up disease progression using modified Stock ankylosing spondylitis spinal score and the cessation of smoking, as it is an important predictor of disease progression, and the new drug targeting macrophage migration inhibitor factor may be beneficial in preventing complication or initiating early treatment of the disease. This is our references, and thank you.